This is something we talk about all the time. Now, if you heard my lecture over the past 2 years, this information is going to start repeating because it is what it is. I'm going to try to make it a little more interesting. I call this the coffee lecture because if you don't have a mug of coffee, you're going to probably fall asleep. But in order to meet requirements for Pennsylvania, Jersey, and Florida, we got to go through a lot of the same stuff over and over again. So we're going to go through the root cause analysis, common misdiagnosis, prevention, and you have to know what a medical error is by definition, and there's a lot of definitions we're going to go through. Last year, everyone asked me, did COVID-19 lead to more medical errors? We're going to get into that today. And the whole idea behind medical errors is really for patient safety. So what are we doing to make it safer for our patients? This don't read. This is the Florida requirement I have to put up. This is what we have to cover, and we will today. So your 2 hours of credit for Florida will be covered. I am licensed in Florida, if there's a problem with that at all. So I want to begin by talking about COVID. We all know what happened with COVID-19. Staff got overran. We had issues with protection equipment, patient compliancy issues. And the thing into 2022 is a lot of the numbers that were reported in 21 and 20 still are being calculated. But according to the Joint Commission, our numbers did go up. We did have more medical errors. And keep in mind that medical errors don't mean that patients had adverse side effects or consequences. It just means that an error was committed. So we had, in 2021, we reached the highest level since they started reporting them in 2007. So did HIPAA, thanks, Dan. Did COVID have a problem with this? And the answer is yes. And they're still doing their RCAs, or root cause analysis, to figure out why the numbers went up so high. You know, we're talking about a sentinel event. We'll get into the definitions later. Are events that cause patient harm. Okay, that's what they want to really zoom in on, is why do patients die or have adverse side events at the time. And those numbers went up about a third in the 1 year. So, so the most commonly reported safety events or reasons for medical errors: patient falls, delays in treatment, and unintended retention of a foreign object. Surgery is number 2 for medical error reasons. Number 1 is still going to be misdiagnosis. And that's really important when you think about why, how that's going to happen, because we all work diligently, but misdiagnosis is still occurring for multiple reasons. We'll get into that. I'm going to begin differently this year because anybody been following what's happening in Tennessee? Of course. No, not of course. A lot of people I talked to so far do not know what's going on in Tennessee. Yes. Show of hands is, and I'm not going to give any more details until does anyone know what's going on in Tennessee besides the one doc down here? We got 2, 3, 4? Okay. This is hitting all the highlights of if medical errors should be criminalized. This just hit in 2019. It's now going to court. So what happened was, in 2017, an RN working in the ICU of Vanderbilt Medical Center, not a rural hospital, a primary care, tertiary care hospital, the main teaching hospital of Vanderbilt University, a nurse was given the order to administer Versed to a patient for sedation for an MRI. She went into the automated system, pulled out vecuronium, injected into the patient, and the patient died. So that led to, was this just more than a medical error? And we're going to go back and analyze this later, and we're going to see how this was a medical error, what could have been done to avoid the error, and now the question is should she go to jail? So in 2019, 2 years after the incident occurred, she'd already lost her license. She was taken off the staff of the hospital. They are charging her for reckless homicide, which they downgraded from criminal homicide, which would take a jail term up to around 10 to 15 years, and an impaired adult abuse, because they're saying the patient was agitated, she didn't know what was going on, and she couldn't defend herself. So she's actually going for hearing next week. She can face anywhere between 3 to 6 years in prison and another 1 to 2 for the homicide. And again, that was downgraded from criminal to negligent. So she lost her license. And I love this name for this newspaper. They must be real original, the Tennessean. I mean, you know, not the Daily Reporter, but the Tennessean. So this is from July, and there it goes. All right, so her name is Redonda Vaught. She was an RN, she was licensed, and now here's been interesting. Okay, the first day of testimony, she didn't try to cover up her error. She admitted to the error. She said it's completely my fault, and that she did not double check the medication before she administered it. That's one problem. How did she get the vecuronium is the second problem. Third problem we're going to see, and we're going to go through this again after we go through it to try to make it more interesting, is where was the patient monitoring? You know, pulse oximeters. They're usually given after you sedate patients in a hospital. You know, I did anesthesia for a long time and came out with the old NEL course before we even had routine pulse oximetry, and you didn't sedate patients without a pulse ox. So that's 3 faults so far. So she didn't shriek. That's her. I mean, she looks really good, doesn't she? She's like nervous wreck at the court case. And here's the thing that really got me with this whole case. Vanderbilt University put in an automated drug delivery system. Okay, so you put in your information, you put in the patient data, the medication comes out, you pull it out of the machine, you draw it up, you administer. Well, it sounds fail-safe, right? But she's saying that the medical center permitted the nurses to routinely, then that's a hell of a word to say, routinely override the system in order to get the medications faster. Well, why would you do that for? Why would you override a system with built-in fail-safe to get the drugs faster for administration? So, and how do you override the system? So what kind of system is fail-safe if you can override it that easily? So she said during her testifying that overriding was something we did as a part of our practice every day. But if you do a root cause analysis, which we're going to get into, how did you not pick this up? How did you not find out that everyone who wants to can override the system? Why do we have a system in place that we can override? You know, she even went as far as talking about IV fluids. So during deliberations, they basically said that there was many mistakes and failures that were involved in this case, but their scope was proceeding was narrow. They had to focus basically on the criminal at that point. And this is the first case that I could find, and I did pretty thorough research on criminal accusations from a medical error. And it says that, you know, we all make mistakes, but mistakes are made and they have consequences. So this is what we're getting into now. Usually you have a medical error, there's no civil lawsuits, and this is the criminal lawsuit too. Okay, so how did we get into this thing with medical errors, and when did it hit the headlines? It all started back in 2009 when the Institute of Medicine came out with this famous book called To Err Is Human. And they noticed that people were dying because of medical errors. So they went out and came out with this publication, and they said, we need to find out why and what can we do about it. So in 1999, there was about 98,000 iatrogenic deaths due to medical errors, and it was the 6th leading cause of death in the US. That number has gone up and down from 3 to 6, and depending which publication you read, you'll find out how it's ranked. But nonetheless, it's still a significant cause of deaths in the United States. So medical errors is basically you don't get to the goal you're looking for. So you can either have a problem with the plan of action or the execution. And then you're going to hear words like omission and commission, which are very important as well. So you have an unintended act of one that fails to achieve the intended outcome. In the case of Rwanda, she had obviously a bad outcome. And we know why, but we'll get into the reasons why it's so important to do root cause analysis in a second. If you deviate from standard of care, that's when you get involved with criminal or legal matters. So standard of care has to be followed no matter what's happening. If you have a medical error against standard of care, we're going to have this problem we have with this growing Vanderbilt. So medical errors are preventable, and that's the key word, preventable. because you can have unintended bad outcomes, but they weren't preventable. They're unintended. So you have a preventable adverse effect of medical care, whether it's evident or harmful to the patient. So you can have what's called near misses, and we'll get into all these definitions because we have no choice. So from the Institute of Medicine in '99, what did we learn? That majority of medical errors weren't from individual recklessness or the actions of a particular group. So they couldn't put the blame on any one person or thing, but they felt it was more due to the system. And they felt that errors were caused by faulty systems, processes, and conditions that led to the environment to cause medical errors. And medical errors can occur from anywhere between starting with writing an order or a prescription, to transcribing that order or prescription, to the nursing, to the administration of the whatever the order was for. And then you're always going to hear about wrong side surgery, retained foreign bodies or foreign objects. They're there. So again, like I mentioned before, medical errors are going to occur either during planning or execution. And it's either going to be an omission, you left something out, or you did something against what you were planning to do, a commission. So the error of execution, and of course the cartoon says everything, is that it's a failure of a plan to result as intended, okay, such as a misread prescription or miscommunication. The nurse had a miscommunication, right? Order was written for Versed, and she gave vecuronium. Think about this, because I'm going to ask you at the end of this lecture, what was the problem with giving the Versed, and how'd she get it from the machine? Okay, so and an error of planning is that the goal or intended action is not fulfilled or is incorrect. All right, incorrect medication prescriptions, and so again, omission or commission, that could be part of what's causing the medical error. And so an omission is actions not taking. So if we don't strap a patient to a wheelchair during transport, they fall out, that's an act of omission. All right. We take a patient into the operating room, if we don't secure the arms and you wind up with a brachial plexus palsy, that's because we omitted doing that part of the procedure. So, and commission occurs as a result of a wrong action. All right. So we administered the wrong drug. We didn't realize the patient has a penicillin allergy, and we wrote for a drug that caused an allergy. One of the relatives is penicillin. So, and one of the things that's happening more whenever you do the research for this is labeling lab specimens. Okay, so if they should be labeled correctly. You got to track them and hand them off appropriately, and not assume that someone else is going to do that. Are all medical records reported? Now, last year, the case in Tennessee wasn't an issue as much as it is today, because now it's going to court next month. So when I go through this, think about how you would be feeling. You're going to want to report medical errors if you have the opportunity to go to court for criminal charges. So the biggest problem with reporting medical errors is fear of punishment. So if you report a medical error, we all make mistakes. Brumwald, we all know the great cardiologist out of New England, he said, I will continue to make medical errors. I just hope my patients never suffer from them. That's how I learn. So yes, fear of punishment is real. And now we're seeing this in Tennessee. So are we going to want to report our medical errors? Because the reason we report is to make things better, not to go to jail. So if we have a fear of reporting, then we're not going to do an RCA. We're not going to look at options to fix, and we're not going to do evaluations to make sure that they're working. So if we have a fear of punishment, this system's not going to work. And so there's anger, there's guilt, there's inadequacy, depression, and how about suicide? Okay, you got these nurses working for COVID, overworked, long hours, no sleep, deprived, they make an error. Now they really feel like, I'll use the word terrible. And so could they be suicidal? Sure. Could they be depressed? Absolutely. They're going to feel inadequate? Sure. So we need to support them as a profession, no matter what level of this error occurred in. So whether, it's something that we need to really be conscientious of. And pending legal action is really coming to the forefront. Okay, so here's the coffee part of the lecture. So there is basically 11 definitions that fill the requirement for medical errors CME. So there's everything from active errors down to sentinel events. We'll go through these. Some of these are going to start repeating, and I apologize, but we have to cover it. So an active error. Active error is when it takes place between a person and an aspect of a larger system at a point of contact. Okay? So that could be something as simple as you writing an order, even if it's electronic, it's taken down incorrectly. Or how about, we all heard of cases where they take the wrong patient down to the OR because they have the same name as the one that's on the schedule until they check the checks and balances and make sure those things don't happen. Active errors are made by people on the front lines, such as clinicians and nurses. And amputating the wrong leg, or the wrong eye, or doing a procedure on the wrong side of a body, they can well occur. I'll give it in that second. Adverse events. So an adverse event is a type of injury that most frequently is due to an error in medical or surgical treatment rather than the underlying medical condition. All right, so we get sepsis after an operation because they didn't prophylactically give antibiotics. That's an adverse event, okay, because that could have been avoided, it could have been prevented. Not all adverse events are the result of an error, only preventable, and that's our key word. We're going to go through that over and over again. Preventable adverse events are attributable to medical error. So an unattended injury in a medical or surgical patient, prolonged hospitalization, physical disability, or both. That's why I brought up the example of the sepsis before. And unattended injury or complication as a result of prolonged hospitalization or disability caused by factors inherent in the healthcare system rather than the disease. So, wrong side surgery, very common, still occurring, but there's a system called timeout that you're supposed to use, which should help reduce that. It's not working. It's still one of the leading causes of medical errors. And is that inherent in the system? Yes. And that's not necessarily a system failure, but if you're not doing proper timeout and you're not enforcing it from all levels, nursing and physician, there's a problem. Latent errors are accidents waiting to happen. Okay, these are things that for a long, long time have gone on, no adverse effects. Until you catch what could have happened. It's the shoulda, woulda, coulda system. And so when you have a latent effect, it's something that goes unnoticed until someone actually picks it up. I don't know about this classic example, but they're just talking about chest tube drainage sets, and they have all different connections. So if you don't have adequate communication with your staff in a hospital settings, especially of how to use equipment, that's an accident waiting to happen. So again, medical errors, by definition, the failure to complete the intended plan of action has an unintended outcome. It deviates from process of care, which may or may not result in harm. And I'm not talking about standard of care, I'm talking about deviation of care. And when planning or executing a procedure, the act of omission or commission, which we talked about. Negligence, okay, this is Nan's department, not mine, but the way negligent cases come to fruition is if you deviate from standard of care. And it becomes really important is what happens in rural areas where the primary care physician is asked to deliver kids. Well, the standard of care is an obstetrician, but unfortunately there's none in the community. So your standard of care is what you can do as a family doctor. But if you're in the city and you're in the same situation, your standard of care is going to be the board certified obstetrician who has full backup from NICUs and all that stuff. So standard of care is very important. The healthcare worker who doesn't check a pathology report, how many people in their office have a system in line that when you write for a test, whether it be radiology or lab, they actually go over it and call the patient? One, two, I feel, not many. That's one of the leading causes coming up with misdiagnosis or delayed diagnosis. So if you don't have a system in order call back your patients and go over these results, you're held accountable. And the big ones are like if you miss a cancer on a film, then you don't call the patient for 6 months, or they call you and say, they found this on my x-ray, why didn't you tell me about it? You know, because you missed the report. You know, I had in my office, because one second, we'll get to the questions later. In my office, I actually had signs up that said, you know, if I write for MRIs or lab studies and you don't hear from me in 2 weeks, call my office. Because, you know, I put a lot of the onus onto the patient because we're all busy and we all have emergencies and we all have shit. So let the patient become involved in the practice. They want to be part of the practice. So I tell them to call me, all right? And then, you know, and I also have good rapport with the radiology department I used, and I would have them call me with any really bad reports. So if I had somebody that was surgical and needed to get done immediately, they call me. So it's a good idea to have that in, and even if you have them sign off on a waiver that they have to call you within 2 weeks if they don't hear about their lab studies, especially if the lab screwed up and never ran the test. That happens still. Yes?
If you tell them but don't have them sign the form, is that circumvent negligence?
That's a legal question. I don't think so, but I just do it because patients need to know, and it just makes, I felt it made me feel better, and it made me look better. Yeah, next question.
Having them call is a great idea. It kind of goes the onus on them. We'll take it one step further, and we ask them to make a follow-up appointment at the front desk to follow that result up, so at least there's documentation that we've done everything.
Sure.
Because we're not in control of who reports and when, and having all the radiology cell phone numbers is also a good thing.
Well, for you or for the patient? Because if the patient's calling the radiologist, they're going to get really pissed off. So, yeah. Yeah. I mean, look, I got it so far. They had my cell phone number because, you know, we're small. I was practicing down here in Camden County, so guys I used, they call me on my cell phone. But I do think that the idea of having some kind of a notice up or having your front staff tell patients to give us a call. You know, Steve, I mean, I know your office must be tough. You're solo and you get a lot of patients and with labs, and they don't all go to the same lab. Some go to Quest, some go to LabCorp, some go to the hospital. You know, so you can't track them all. Yeah, Steve.
I mean, I'm in a paper system, but I have a thing where, like, it's each day of the week, and all the back copy of all the lab slips go in there, and only when the result comes back do we pull it out. At the end of the week, oh, this didn't come back, let's go online and find the result, or what happened.
Okay, so how do you track that? So do you have a system? So Dr. Cable, C. Cable, solo practice, paper charts, and he was saying that all the labs that he writes for or radiology reports go into a bin. He goes through them, and then they get filed once he reviews them.
I have a file, like on the wall,
right.
Where when you order, say, we order a lab and it goes to class.
Mm-hmm.
The front sheet goes to class with the lab.
You're taking the yellow copy.
Goes
Yes.
to the tickler thing.
Okay, that's lab. What about radiology? What about radiology?
I tell the patient to call me 5 days because I don't know when.
Right. How about the specialist report? Okay, you got somebody who's got an arrhythmia in your office. You send them to cardiology.
Yeah.
Okay, and you're waiting for the report to come in, and the patient never even went to see him. You know, so how do you track all that stuff? That's all part of medical errors. So I don't want to get into any more tangents, but I'd recommend that everybody have something in their office for compliancy of reports. It's going to save you a lot of aggravation. And does anyone know what the fastest area of medicine with malpractice cases is as of 2020? It's radiology. It's missed cancer. And that's the misdiagnosis part. So if they miss it and you get the report, okay, and you don't go over with the patient, you're going to be held liable down the road. Why didn't you tell me I had cancer back then? Well, I never got the report. Well, it's not, you know. So be careful. Negligent, again, adverse events. It's a subcategory of preventable adverse events. And now you're getting into the legal. See the word negligent? Okay, that's what that nurse at Vanderbilt was. She was negligent in her administration of the vecuronium. And the injury caused by substandard medical management. She bypassed the fail-safe drug delivery machine. Think about that. She bypassed the fail-safe machine that they put in to prevent medical errors with pharmacological drugs. Near miss we talked about. It's the shoulda, coulda, woulda. The accident's waiting to happen. They changed the way you do timeouts. And, you know, for those of you who don't know me, I do interventional pain management for 31 years, ran ORs for about 5 years. And when you do a timeout, the surgeon was allowed to basically mark any way they wanted to the person. Is Cliff here? No, we had an orthopedic surgeon for a while. So now you can't do it that way. You can't write no, you can't write yes. Legal standards of today say you have to put your initials, the operating physician's initials, not the resident, not the medical student, and not the nurse, on the area you're operating on with a skin marker. Okay, so if I'm doing right knee arthroscopy, I'm not putting no on the left knee, I'm putting my initials on the right knee. Okay, and that's got to be verified by the charge nurse, the circulating nurse, and any scrub techs that are there too. So if I write on the right knee and I'm supposed to the left knee, that's a near miss if they catch it. If they don't catch it, then you have an omission. Okay, a never event are things that should never happen. Okay, well, theoretically, no medical error should ever happen, but they do. And does that mean it was preventable? That's the key word, is preventable. So where can you have a problem with a never event? Well, you should never operate on the wrong leg or amputate the wrong leg or do the injections on the wrong side of the patient. And so your never events will vary between care down to radiological, and most of them are avoidable. Noxious episodes, untoward events, complications, and mishaps that result from acceptable diagnosis or therapeutic measures deliberately instituted. So this doesn't mean it was necessarily a error with the way things were carried out. It's just an error in the way things resulted. So it's an untoward event or complication. But what you did was acceptable. You treated the patient according to what the standard of care, but the outcome wasn't where it's supposed to be. And the example is spot on. So you have a trauma patient that comes in, and you got to get a CT scan because you wonder where the bleeding in the abdomen is coming from. But it took too long to get the patient through a CT scan, and they died. So should you have hemodynamically stabilized the patient first? Yes. And then gotten your CT scan. So that's a noxious episode. So getting the CT scan is medically acceptable and is actually in the algorithm for treatment of that patient. But at the time they got it, it wasn't appropriate. So the root cause, this is the essence of this whole talk. Root cause or root cause analysis. You have an error, okay, you report it. And it all starts with an incident report. Okay, so you file the incident report. Then what you want to do is you want to see what is the problem, what was the deficiency, and what can we do to eliminate this problem in the future. I can guarantee you that RCA for that nurse at Vanderbilt is pages long. So if you don't do an RCA, identifying the medical error is useless, and you're going to probably have it happen more than once. Okay, this came out of the Florida, I don't know, it's the Florida Board of Medical Examiners. This is their slide on medical errors, and I like it because of this. If you look at the way you work up an RCA, you get your data. Well, that makes sense. Okay, wrong side surgery. Let's go through the last 1,000 cases and see how many had wrong side surgery. Okay, then here's your team. Well, your team's not just administrators. It's got to be your physicians. It's got to be nursing staff, depending on what the error was. Identify what happened, okay? And that is, so there's nothing here that talks about assessing blame. And that's what's paramount. There's no blame here. So you talk about your casual factors. Then you sit down and say, all right, how can we avoid this in the future? And I'm going to bring up a case in the second half of this talk of how this was done successfully. And I'm going to show you how medical error rates came down dramatically. You can implement all the solutions you want, which is good, but the big thing is you have to assess them. You got to review. So if you put in a new policy that says, all right, same side surgery, we have to mark with a skin marker, we have to have it witnessed by the nurses, that's great, but go back and make sure it's getting done. Because compliancy, and people get lazy. And I've been there. I've been in the OR where doctor says, let's just go. No. You don't just go. You got to make sure it's done appropriately. And you're going to come back and you want to make sure that everything you've done is sustainable. Okay, so you can have problems with your root causes. It could be human error, it can be a mental error, it could be a communication error, it could be a collaboration error. There's a lot of reasons why errors occur. And the things to take out of this slide is, not everything's automatic. It looks like a duck, quacks like a duck, walks like a duck, doesn't mean it's a duck. Okay, you remember the old Volkswagen commercial where it was a sheep in wolf's clothing and they took off the sheep and it was actually the wolf inside? That could happen if you get too non-compliant with or complacent is a better word, with your treatment of medical care. Communication, don't assume anything. Don't assume that something's going to get done. And check on it. Make sure it is getting done. Because this is where the errors are going to occur from. Communication is usually one of the leading reasons for medical errors. And you have to be able to identify your patients. Incomplete assessments, admissions, you forgot to ask about allergies. Okay, you forgot to ask about previous medical conditions. And then all of a sudden you're starting to administer medications that are contraindicated. So the common root causes, when you do your analysis of why medical errors occur, inadequate policies to guide healthcare workers. Well, most healthcare workers aren't reading policies. So it's more like communication. You have to talk to your team and have a good working relationship. And that includes everybody. And if you do find a problem, then it's time to review your policies, go over them, update them. And like you heard Nan just talk about updating again for HIPAA at 2022 or 23. So everything's constantly got to be updated. Lack of consistency. You can't make exceptions. Okay, a surgeon's in a rush and says, I don't have to mark, let's just go. No, you can't have that. You've got to have consistency. And no matter what you're doing. Inadequate staffing or poor supervision, that's going to occur mostly when you have people that are filling in. If you have a team that works, and it doesn't have to be just your team, it could be all the doctors' teams, that work together and are coordinated and they collaborate and they communicate, that's going to avoid that. So if you have somebody who's new to the system, take the time to make sure they understand what they're supposed to do. Or have somebody do it for you if you don't have the opportunity. Medical equipment, if you don't understand it, don't touch it. Get somebody who does know what's going on. Technical failure and also audits in the system. It's basically just looking at the results. We talked about the root cause analysis and putting in new policies and looking for options how to fix it. Well, make sure it's working. And no one prepared to accept blame or change the system. Well, nobody ever wants to take blame because we talked about that before. You feel like the guilty party. But sometimes you got to stand up and man up to a mistake. Maybe there was no harm done, but now maybe we can figure out how to fix the system. So a sentinel event is all the Joint Commission really cares about. So this is an important definition because a sentinel event is an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. And the risk thereof includes any process variation for which a recurrence would carry significant chance of a serious adverse outcome. Okay? So if you get a sentinel event, you got to report it to the government. It's major paperwork. And that's going to cause an immediate RCA. And they're going to want to see your results of the RCA and what are you going to do to fix this problem. And you better believe there was a sentinel event at Vanderbilt, and they rewrote all their policies. So sentinel events are so called because once discovered, they frequently indicate the need for immediate investigation, discovery of the cause, and response. So if you even have a problem in your office, now Florida requires doctors, and I'll go into this in a second, even if you admit a patient to the hospital from your office, that has to be reported. Okay, so even though there's no medical error, it has to be reported. They're trying to avoid the sentinel effect or event. This has to be presented today. The Florida Board of Osteopathic Medicine, the 5 most misdiagnosed conditions, and this slide has not been updated in a couple of years. Inappropriate prescribing of controlled substances. They're referring more than just pill mills. They're talking about patients that give an OxyContin or long-acting opioid as opposed to a short-acting opioid, or giving it for too long. Failure to monitor the safety of prescribed medication. They're not looking at their systems. Retain foreign objects in surgery and wrong site surgery. Still up there. I don't see many cases in the literature about foreign objects still being an issue, but especially I do see wrong site surgery still occurring. Remember last year when I was sitting in Florida and we talked about the case in, I think it was Michigan, where they did wrong-sided brain surgery? You know, so it's big stuff out there. So surgical complications or errors for preoperative evaluations, including obtaining informed consent. And if you're doing a timeout, like we just talked about, well, the consent's got to be there. You know, it's the first thing the nurses look for is consent. So does anesthesia. And if it's not there, you can't really go any further in the holding area. And failure to timely diagnose sepsis. So the Florida requirement says that all licensed healthcare facilities, and this has been expanded to include physician offices, establish an internal risk management program that includes investigation, analysis, and frequency and causes of adverse events in the office, in the hospital setting, appropriate measures to minimize the risk of adverse incidents, and again, this is all that RCA again. Analyze the analysis of patient grievances. They relate to patient care and quality of medical services. A system for informing a patient or individual identified pursuant to state law the patient was the subject of an adverse incident. So notify the patient, you know, man up, and basically just tell them there was an incident. Don't assess blame. It's just basically saying we had a mishap. And the development and implementation of an incident reporting system. It requires all agents and employees to report adverse incidents to the risk manager within 3 business days after the recurrence. That's hospital. Office isn't as bad. Patient safety, this is what the Joint Commission is trying to do. They're trying to, it's a process of amelioration, avoidance, and prevention of adverse injuries or outcomes that arise as a result of the healthcare process. So that's all they're trying to do is reduce bad outcomes. So if you look at the most common medical errors, again, this is all for Florida again, a misdiagnosis, and that's, you know, a wrong diagnosis and a misdiagnosis are different. You know, I always used to think of medicine as being like a, you know, like a puzzle. We get all these little pieces, and we're trying to put it together and come up with an answer. If you have a wrong diagnosis, you correct it, you get back on track, and so, you know, you didn't go after the most common cause. Patient could do okay, but a misdiagnosis is going to lead to an adverse effect. Delayed diagnosis is what I'm finding is really climbing on the charts for medical errors, and we talked about some of them before. Miscancer, you know, things that just for some reason get delayed or not discovered. So, and that's why I brought up that topic before about having something in your office for implementation of calling back your patients or getting them involved in calling you to find out results, okay? Medication errors, we talked about the one from Vanderbilt, we'll talk about some more, but I'm not going to get too much into abbreviations and writing drugs wrong or sloppy prescriptions because it's covered every year, and I'm trying to get away from that. Bad medical infections, well, infections aren't necessarily an error unless they go undiscovered and lead to prolonged hospitalizations. And if I'm not mistaken, if you have an infection after a procedure, that's no longer reimbursable. You know, you got to cycle up that cost if it leads to prolonged hospitalization, unless the infection was not due to your mishap. So great thing with infections, prophylactics, antibiotics aren't given, or an inappropriate dose is given that leads to that infection. That's a medical error. Bad medical devices or systems. Is that a physician error? Not necessarily. And just bad treatment. You know, you took a patient down to the x-ray, but they fell off the gurney. Yeah, that's just treatment error. And so a medical error can occur during ordering. You know, clearly you ordered the wrong medication. You wrote down X and it turned out it looked like a Y. Transcribing, you know, and so instead of asking a question, you know, what do you mean by this? They basically say, oh, this is what he must have meant, and that's wrong. Dispensing, sure, you're going to dispense what's written, but if you can't read what's written, or there's the wrong medication written, or you didn't check for allergies in the patient, that dispensing wrong, delivering wrong, administering, and overwork and fatigue. Boy, that's COVID-19 right there, overwork and fatigue. So from 2013 to 2017, again, the most common source of medical malpractice claims, because this is deviation from standard of care and negligence, was diagnostic errors. Okay, 33% of medical malpractice claims at that time were related to errors during patient diagnosis. Now you see why I'm getting into that. In your office, get a system, okay? Because that's going to ride that number straight down. Because if the patients don't get notified again, we're in trouble. Okay, so diagnostic errors. Okay, failure to employ relevant tests. You got a patient who's diabetic and you don't bother checking A1C, okay? Or you don't do anything routine. Using outdated tests, I guess. Like IV bleeding time, okay? I used to order that all the time for my patients who, I may have a bleeding disorder and I had to do injections on. They're outdated. They don't do this anymore. But if I order it and it's not appropriate, and it leads to a complication, I'm held liable for using an outdated test. Reviewing diagnostic materials. Been there, done that. We talked about that ad nauseam already. Mistakes in diagnosis. Failure to act on test results appropriately. I think it goes with what we talked about with the notification of patients. And cognitive errors. Don't get cocky. If you need a consult, get a consult. If you need to bring somebody in for another opinion, bring them in. It's like we used to say, if you can't get an epidural in or a spinal injection in, don't keep trying. Get somebody else to do it. So cognitive errors are just, a lot of them are caused by just failure to just think things through and get appropriate help when necessary. So again, for Florida requirements, the diagnostic errors, wrong, delayed, or missed, cognitive and system, failure to employ indicated test, outmoded test, failure to act on results of monitoring or testing, and there you go. We will call you if there was concern, no need to call us. Telling you, do it. I'm lucky I'm retired. Okay, so no fault diagnostic errors is basically what it sounds like. It's not your fault, okay? Things happen. It stemmed from outside the control of the physician or the healthcare system. Okay, so they have an atypical presentation. You treated it like it looked like, but it turned out to be something else. Or the patient never told you about underlying medical conditions or allergies or surgeries. So your diagnosis was off because you had misinformation from the patient. Is that a medical error? No, not necessarily. Okay, so the 7 stages of the diagnostic process. You have to assess. You have to take a good history. I mean, this is all standard osteopathic medicine. Good physical examination. Order the appropriate testing. Your assessment, referrals, and follow-up. And so your error can occur in any one of those stages. So it's important for us to realize that we're responsible for all these stages, and we're the provider. Okay, so if your history is done via computer, like on an intake sheet, some kiosks, go over that with the patient. They don't even understand a lot of this stuff, and they just want to get it over with. And you'd be surprised how often you'll find out, like, did you have surgery before? Well, no, but, oh, yeah, I had surgery done, but I didn't consider that surgery because it was minor. Well, there's nothing minor in life, right? Or they didn't tell you that they had a heart attack 7 years ago because now they're stable, but they didn't tell you that. So, but we need to go over that information because it's important, and we need to know what's going on. Physical examination, well, if you can't, everything should correlate, obvious. And we went through a lot of other stuff before too. This slide's complicated. Basically, it's because it's the FOMA slide and we have to present it. Cognitive errors and system errors are the 2 reasons for most of these medical errors to occur. So the big thing I want you to realize is over here. Just your processing, okay? Don't get cocky, okay? If you think everything's going right, fine. If not, don't just assume it's going to be okay. Get help, all right? Get a consultation. Get a second opinion. Latching onto a premature diagnosis. Well, that's before you looked at all your labs and you looked at your radiology reports and you didn't look at your physical examination. And then you find out, oh, I administered everything incorrectly, and now the patient has a problem. It's a medical error. And again, abandoning search for evidence to the contrary. Well, if I'm treating according to the algorithm for this disease, but the patient's not getting better. Well, nothing I can do. Send them home? No. Look for another alternative. See what else is under the rock. All right. System errors occur between the pieces of the system, and that includes staffing. Others involved in care and dropping the ball. That happens a lot. And consultation process with the hands off, you know, I can handle this. Ego. Ego is going to kill you. Don't do that. And, you know, loss or unreported test results. We're back to this again. Here we go, you know. So in Florida, the 5 most common medical errors and misdiagnosis: cancer-related, surgery complications, respiratory-related conditions, and that was pre-COVID-19. I'm sure that number is going up dramatically. OBGYN conditions and cardiology. So that's where most of our medical errors are coming from. And treatment errors include errors from performing tests, performing treatments, procedures, inappropriate care, and occur errors in dose and drug administration, and delays in providing treatment. Okay, preventative errors. Errors resulting from inadequate monitoring. You're going to administer Versed to a patient for sedation. They're already agitated. They're old. They're cognitively not there. Should they have had pulse oxygen? In that case in Tennessee? They're all over the place. Okay, inadequate follow-up treatment. There we go back to the office setting again. Get these tests, whatever you do, just make sure you keep following them. We talked about infections and sepsis, and if you don't prophylactically appropriately for the diagnosis, you're held accountable. It was preventable, and includes fair and communication. Sign off. I mean, we all used to do rounds, and you know, we used to. Well, at least I did as an intern and resident. You know, you worked at 24-hour shifts. You come back and you sign off to the next person. It's communication. If you don't tell them to check up on a lab or a study, you're going to be held accountable for medical error for failure to communicate. You know, equipment failure. I don't think it's a physician error in that case, but clearly it can happen. And surgical errors. So we'll go through these real quick. And here we go. A patient came in for tonsillectomy and winds up having a hysterectomy. That's a little bit far-fetched, but it occurs. So the most common basis for quality of care violations is wrong site or wrong procedures in surgery. Again, it's not leaving the list. It's still the #1 problem. And if we amputate the wrong leg, oh boy. You know, and has it occurred? Yeah, it's happened in New Jersey. I was on the board for NJSSA, which is the Society for Anesthesia, and we reviewed cases of medical errors from surgery. The number one problem from anesthesia-related mishaps back in the early 90s, because we stopped at about 94, 95, was failure to be able to get a patient out of an office for an emergency. Okay, so, and that was mostly with dental. So, and we talk about quality of care. So dental surgery in the office, they give nitrous. Back then, they would give some diazepam, whatever. Patient had a problem, reacted to the epinephrine, whatever the case may be. They couldn't get the gurney in the elevator. It was too narrow. They had to stand them up straight, and that was an issue. So there are a lot of problems in it that occur that can be avoided, and it's just proper planning ahead of time as well. So wrong site, wrong procedure, should never really occur. I'm going to show you in the second half of this presentation an article that we'll go through that actually corrected this. Okay, so disclosing medical errors, again, for Florida, this is what you have to do. According to the statute, you must inform the patient or the patient's legal representative in person. I always would probably do it in person rather than a letter. About the adverse incidents that result in serious harm to the patient. Even if it's just not serious harm, communication is still the best. You know, they talked about malpractice for years. It's always, if you can communicate with your patients and you have a good rapport, they're least likely to sue you. So, you know, talk to the patient, talk to the family, tell them what happened, and tell them what you can do to try to fix it. Notification of outcomes of care that result in harm to the patient governed by the disclosure statute shall not just constitute an acknowledgement of admission of liability, nor can such notification be introduced as evidence. Important to protect the person, nursing, physician, whatever, who tells the family and the patient about the problem, that's not an admission of guilt. Okay, it's not an admission of a malpractice suit. It's just an admission of a medical error that occurred. And here's, you got to notify. If you want it, it's here. If you don't want it, that's fine too. Now here's what they added this a couple years back in I think 21. So the Department of Health requires physician providers. Now it's not even physicians anymore. It's physician providers, NPs, APNs, PAs, to report adverse events in the office setting, and also they have to be transferred to a hospital. So that's where that changed in 21. Okay, so when you disclose a medical error, obviously you want to obtain legal advice. Yes, Steve?
Is that only for errors, or if the patient just comes in and you decide, oh, they have an emergency, but you haven't even done anything, you transfer them?
If you transfer a patient from your office, it's not routine, you have to report it. Doesn't mean you can be held, it's not an error, just has to report it.
So even non-error things, just
Yeah, I'm not sure every physician is going to do that because, like you just said, a patient comes in with chest pain, you're not even going to waste the time filling out a form. You're just going to call 911 and get them the hell out of there. So, but that's what they're saying. So, be it as it is. Okay, so we're talking about when you disclose medical error, obtaining legal advice, always advisable. Communicate, be open, and I really believe that honesty is the best policy. If you look at reduction of malpractice risk, communication is key, and don't be arrogant. It wasn't my fault, but just admit it happened. Don't admit guilt, but have some empathy. Communicate. Don't blame. What are you going to do about it, if anything? Confirm understanding, and just document it. It's all pretty common. Okay, and guidelines for patient care by U.S. Department of HHS. Okay, so in order to improve patient safety, we have to identify the patients correctly. And we can snicker about this, but last year I presented the case. They brought their one patient down for surgery. Same floor, same name, same middle initial, different birthday. Didn't catch it, and they already sedated the patient before they brought him down. Okay, they gave him pre-op sedative, brought him downstairs to the operating room. I forget what state this was in. It was not New Jersey. And only because they did a proper timeout, the birth dates didn't correlate, and there was no consent form. Took the patient back upstairs and brought the right one downstairs. No harm done, except for the sedation, if you consider that harm. But, so we think identifying patients isn't important. It sure is. In fact, most ORs, they don't even accept physician acknowledgement that they know the patient. They have to have picture ID, a legal picture ID, driver's license, for example. Okay, you just can't come in and say, I'm Tom Jones, and the doctor says, yeah, it is. No, you got to be able to secure, identify the patient, not just by facial recognition. So using medication safely, well, of course, they're talking about even as simple as outpatient pharmacy prescriptions. You want to prevent mistakes in surgery? Sure. You want to prevent patient safety risks that occur. We talked about the example of falling out of a wheelchair, office-based surgery care, and long-term care. And again, I was just really taken back when I did the studies back in the 90s about how the incidence of dental mishaps lead to patient demise because they couldn't get the hell out of the office. It's kind of scary. All right, so this is the first half of my lecture. I know I get real wordy, and we went an hour, so we're going to take a break. Let's give it like 10, I guess, or 15, whatever. Second half won't be as boring, but that was all the crux for the CME part, and next part should be a little fun. Any questions? Okay. One thing, with Nan's lecture, I wanted to ask her, but she left already. When I closed my office down, I had EMR, and I actually called my company and said, what do I do? And they said, burn your hard drive. Do not recycle it. So you know how your city or county, municipal, or Staples, they'll all take your computers and they'll recycle them? Burn your hard drive. I took my hard drive out, and I actually took a hammer and smashed it. Because they don't know how much footprint's left over, and they don't know who's at those stores, and you're not signing a HIPAA compliancy form. Okay, so you don't have a BA form when you recycle your equipment. So if you think there's any chance you have any kind of footprint in your computer, take your hard drive out, smash it, sulfuric acid works great, and then you can get rid of everything else. And you can't just put them in the trash. Yes, Steve?
It's not just computers, it's also faxes, photocopiers, they all have hard drives that memorize it.
Okay. So facsimile machines and all that stuff. All right. We're out of here for 10 or 15. We want to adjourn at 20 of. Does that work?